The topic that we'll be addressing today is telehealth delivery of trauma-focused cognitive behavioral therapy with Hispanic youth before and during COVID-19 pandemic. Our presenter for today is Dr. Rosaura Orengo. She is an assistant professor and bilingual clinical psychologist at the National Crime Victims Research and Treatment Center within the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. Her research focused on addressing mental health disparities among underserved populations, specifically Hispanic youth, through innovative implementation and dissemination methods, including telehealth. She is also an active program of research focused on cultural adaptation and international dissemination of trauma-focused assessment and intervention. She directs the Puerto Rico Outreach Model in Schools Esperanza Project, a SANSA-funded program aimed at bolstering resiliency and promoting psychological recovery among Puerto Rican youths after Hurricane Maria. She also co-directs the USAID-funded program aimed at creating trauma-informed systems and services for children in El Salvador. Dr. Rosaura Orengo is a psychological first aid and skills for psychological recovery trainer, both in Spanish and English, and led the translation of the official SPR manual. She is also an expert in trauma-focused cognitive behavioral therapy and has co-trained over 75 psychologists in the Caribbean and Latin America in this treatment modality. Dr. Orengo Arguello co-directs the World Changers Lab at the Medical University of South Carolina, whose mission is to change the world one child at a time. Welcome, Dr. Rosaura Orengo. I want to remind you that all MACTC network activities uses affirming, respectful, and recovery-oriented languages in all our activities. And this presentation was prepared for the National Hispanic and Latino MACTC under a cooperative agreement for the Substance Abuse and Mental Health Services Administration, or SAMHSA. All materials appearing in this presentation, except that taken directly for copyright sources, is in the public domain and may be reproduced or copied without permission for SAMHSA or the authors. Now with Cindy to a quick poll questions.
Hello, everyone. You'll see a question pop on your screen. I'm going to read it and you can answer it. The first one is, there is preliminary but encouraging scientific evidence supporting the delivery of TF-CBT via telehealth. Select one of the following, true or false. You can vote clicking on the screen. We have a result of 85% answering true and 15% answering false. Let's do the second one. It is not necessary to establish a safety protocol with my patients prior to beginning TF-CBT via telehealth. Again, please select true or false. We have 40% answering true and 60% answering false. And the last one. Mental health practitioners should familiarize with the telehealth guidelines and best practices prior to delivering TF-CBT. And we have 38% true and 62% answering to false. Now I leave you with Dr. Orengo for the rest of the presentation.
Well, thank you so much for the opportunity to be here with you today. My disclosure is that this work is in part supported by a Substance Abuse and Mental Health Services Administration grant, specifically from the National Child Traumatic Stress Network. We're very grateful for that support. I also want to start acknowledging that everything you're going to hear today is a team effort. I want to acknowledge all of our wonderful collaborators at MUSC, at North Dakota, at Texas, Puerto Rico, and Dr. Regan Stewart, who's the director of the Telehealth Outreach Program, and Meg Wallace, who's the coordinator and lead project therapist for the TOP program. And I'm just here as one of the team members presenting this great work, and hopefully we get to learn a few things today. So we have a lot of goals for today, but really I hope that by the end, this will be a successful webinar if we all understand what's the current state of the evidence for telehealth delivery of trauma-focused cognitive behavioral therapy, with a specific focus on underserved youth, in particular Hispanic youth. I also hope to describe the logistical and practical tips for implementing TF-CBT via telehealth, but also keep in mind that a lot of what you'll hear applies to all of our work with children and youth via telehealth. Throughout, I've woven in cultural and linguistic adaptations when implementing this treatment modality via telehealth, in particular with Hispanic youth. And I've also woven some specific challenges and also facilitators of implementing this type of treatment modality during and after COVID. And I'll give you some great references at the end where you can find resources, read papers on this. So I'm really excited. You know, we have to recognize before we talk about telehealth that even prior to this global pandemic, we had a crisis of trauma exposure where 1 in 2 youth are going to experience at least one potentially traumatic event in their lifetime, before they reach the age of 18. And we know as clinicians, as providers, that trauma has significant comorbidities with not only PTSD, depression, anxiety, but also functioning in terms of academic and social skills. And we also know that trauma does not affect all youth equally. In fact, there are significant disparities in exposure and access to care, particularly among our racial and ethnic minority youth. National representative surveys, in fact, show that Hispanic and African American youth endure higher rates of trauma exposure and greater rates of re-victimization. And in particular, there's emerging work showing that Hispanic female youth are a particularly vulnerable group, with approximately 1 in 3 endorsing some form of trauma exposure. What's even more concerning is that despite being highly exposed to trauma, Hispanics are less likely to have access to mental health services. And when they do have access, they're less likely to complete services for a host of reasons. Some of these are concrete barriers that we've seen in our clinical practice. For example, access to the mental health care facility, lack of transportation. It's not just having a car, but having money to pay for gas and parking, taking time off from work. I recall a family letting me know that even though they live 30 minutes away from our clinic, coming to our appointments weekly involved around 4 hours by getting the kids picked up from school, driving, parking, going to a 90-minute session, returning to home. On top of that, we in the United States in particular have a lack of access to bicultural, culturally competent, linguistically competent clinicians who can provide these specialized services in Spanish for most of our families. There's long wait lists, there's stigma. So I primarily work with immigrant youth from Central America and the Northern Triangle, and there's a perception of going to a mental health provider is for locals, people who are crazy, or it's just never been accessible in their country of origin, and thus this is a new service. And most recently, we've all been in it. When we're told we can't provide in-person services, what do? So telehealth during the past year has been a potential solution. I will say our team has been doing this work since 2011 prior to COVID, and more recently in the last 3 years have published data that I will show you. But just as a recap, when we're talking about telehealth or telemental health, we're referring to interactive use of technology such as this one via computer or tablet, where we're providing mental health care services in real time in order to minimize barriers in access to care. And this is an alternative to traditional modes of delivery, such as in-person services. And oftentimes when I talk to my students or do presentations to, across the world, it's very interesting. There's this myth that telehealth is new, that it's something that we came up with because of this pandemic. And the truth is, telehealth has been around for a while. It started in the US through the Army and the entire VA system, and has really trickled down into private practice and community practices over the years, primarily for psychiatric medication management. And really, as in most circumstances, a crisis brought an opportunity for widespread dissemination during COVID. There's evidence showing that telehealth is effective in the US and globally in low to middle income countries. We have evidence that is just as effective as in-person treatment with high satisfaction rates from clients. And it's really important to note that it's providing the same standard of care. We're not modifying our evidence-based protocols, we're just modifying our mode of delivery. So here are some references that I think everyone should read to make sure we're grounded in the literature. I know the focus of this presentation is not on adults, but I did want to highlight that there is significantly more evidence available for the efficacy of telehealth for trauma amongst adults. There's randomized controlled trials, non-inferiority trials for prolonged exposure, cognitive processing therapy, and a meta-analysis showing us that this is effective and it can be done via tele. It's just as effective as in person. And we don't see any adverse effects of delivering it via telehealth trauma treatment for adults. The literature amongst children is more limited. In fact, really prior to this year, the only empirical papers published on trauma treatment via telehealth have come out of our group at MUSC. The first paper by Jones et al. In 2014 establishing some preliminary guidelines for developing this program. And if you're listening, I just love what the team has done prior to my existence at MUSC, where there was a need. We had a lot of Hispanic kiddos showing up for a meeting with one clinical psychologist, the only one in the state at the time who spoke Spanish, Dr. Michael Varellano. The demand was high, the supply was not high. So what do we do? And so how could we leverage technology? And that's how it started. Later, in 2015, we started the telehealth outreach program under directorship of Regan Stewart. And we started with some case studies examining how can we set up these clinics in schools so that an expert trauma clinician who's bilingual, who's well-trained, can connect from a main medical center and decrease that barrier in access to care. And more recently, some more concrete pilot studies have emerged, which we will discuss. But first, let's talk about what trauma-focused CBT is real briefly for those of you who may not be as familiar. I think it's an excellent therapy to really use as a model for that next step of telehealth because it's empirically validated, multiple randomized controlled trials over the last 20 plus years, 30 plus years showing efficacy, effectiveness, not only in the US, but across the world with Hispanic, Latino children, African American children, etc. And it's an evidence-based treatment based on CBT principles. It's for ages 3 and 18, and it's multi-component. And what does that mean? There's 8 different components that providers go through with the child and parallel with the caregiver, where we're teaching basic psychoeducation on trauma, basic coping skills on how to relax, how to identify emotions, what are thoughts, how do they relate to how we feel and how we behave. Once that base is established, we transition into the active ingredient of treatment, which is exposure work. And this is done through a narrative process where the child tells their story via a book or another creative method, and we process their thoughts and feelings during the traumatic event, what they learned in therapy, and then that story is shared with a caregiver that's supporting and believing. And we prep that caregiver throughout treatment to listen to that story, and we conclude with in vivo exposure and safety enhancement. I want to say I'm really excited to report there's a web course that you can take online. It's been translated by our team to Spanish now, TF-CBT Web Español. There you can find the link, and the handouts are included as PDF format. Please check it out. It gives you 11 CU credits at a very low cost. So we're very excited about this product. Now, our clinic in the early 2000s, started by Dr. Michael D'Ariano, began developing this outreach model where how can we bring evidence-based trauma treatment to kids? The problem is not that we don't have things that work. It's that we can't get them to the families in most need, in particular a Hispanic Latino community. So the telehealth outreach model draws from this original model, and it's a three-prong approach. And as you're listening, I want you to think about how already in your own practice you incorporate these valuable lessons learned on engagement, right? So the three-prong model is evidence-based treatment that works, but that's not enough. How can we combine that with intensive case management and engagement strategies? And how do we add telehealth, the cherry on top, as a method to increase access even further? So what do we mean by intensive case management strategy? So in our program, we're not just providing TF-CBT via telehealth. We have case managers who actively work with the families to assess Maslow's hierarchy of need and connect our patients, our Hispanic Latino families, with access to basic services, applications to Medicaid if possible, food banks, clothing, housing concerns. And as an example, we have this quote from a mom translated to English where she tells us, I can't worry about my child having problems at school or my child not listening to me at home while I'm making sure that I can get him to school and that I'm making sure he has a home. So this is really important to note that telehealth won't solve anything unless we also complement our services with comprehensive wraparound services. Also, we need to engage caregivers. We need to engage patients, and we do this through addressing concrete attitudinal barriers like stigma, orienting, joining with that family, listening to their concerns, incorporating traditional healing practices and views, always keeping our own biases in check, but also incorporating technology through text messages, reminder calls, etc. So it's very important to keep that in mind. Now let's move on to some initial data. So, this is the culmination of 3 years of a real clinic in South Carolina operating with psychology interns, MSW clinicians, faculty members, all providing TF-CBT via telehealth in two contexts, schools and homes. So remember, this is prior to COVID. And in this pilot study, we had 70 children participate, about 19% male, 81% female, ages 7 to 18. And I think it's important to highlight, this was not done in by targeting Hispanic Latino clients, but we ended up with about a 58% Hispanic Latino sample and a 30% African American sample. So significant ethnic minority representation. And on top of that, almost 1/3 of our cases were completely done from beginning to end in Spanish. So it's really important to note that this is the work that drove this data. We targeted 7 underrepresented communities in the state of South Carolina, and 63% of the kids were seen in school. And what we mean by that is that we had equipment, a private location, and a protocol set up where children could access their therapists during school hours, either through a study hall or a class period where they were excused. And 34% had home-based services, meaning that for this family, it was determined that the child would benefit more from having a loaner iPad taken home and receiving services while they were at home after school hours. And now for the results, which are really exciting. So I want to highlight, this was not a rigorous scientific study. This was program evaluation work of real-time progress. And we had 62 of 70 patients complete all treatment components of TF-CBT. That represents an 88.6% completion rate. And to give you an idea, in traditional randomized controlled trials of TF-CBT, where there's the research component is the primary focus, typical completion rates are lower, 25 to 60%. So already we're showing that telehealth increases access for our particular racially and ethnically diverse populations. The treatment effects were large, a 2.42 effect. For those of you who aren't familiar, anything above 1 is a large effect size. And 96.8% of children no longer met criteria for post-traumatic stress disorder. On top of that, we had high caregiver engagement. So 81% of caregivers participated actively in sessions, received the skills, listened to this trauma narrative. And for those of you who work with parents, you know how hard it is, but we were doing something where they didn't have to leave work. They could access our therapists via their phones or a tablet during lunch break hours, in their car while they were on a break. And we had high caregiver satisfaction, which I'll talk about in the next slide. I encourage you to check out this publication if you can. It was published in early 2020 in the height of the COVID pandemic, where you'll find more information. 100% of our caregivers report satisfaction with this treatment modality. 100% said level of rapport was just as good as in person. 100% said they would recommend telehealth to a family member or friend. And our biggest challenge, which was still 86% said the equipment was easy to use, but families really struggle, as I'm sure you've noticed this year, with that initial setup. How do I get the technology to work? How do I download the application? So those are the things we still need to work on, which we'll talk more in a second. And this publication is under review. Dr. Bianca Villalobos is running these efforts, and I just want to praise her so much for all her hard work. So in conclusion, what does the data tell us right now? 9.5 out of 10 children, so almost all children improve with TF-CBT via telehealth in the sample. And almost 9 out of 10 complete full services via telehealth, compared to more 2 to 6 out of 10 in traditional non-telehealth work. Very high satisfaction rates, and we increase access for our Hispanic Latino youth, which is so important. So right now, TF-CBT, the preliminary evidence is encouraging, but we definitely need more controlled studies, but we have very encouraging preliminary evidence. So to summarize, maybe you have seen this, that there are certain advantages to telehealth beyond COVID. You know, decreasing common transportation and distance barriers, reducing needing childcare, working around family schedules, and increasing the likelihood of treatment completion. But there are some challenges too. So, you know, it's interesting. Let's talk about them. So telehealth logistics. I just want to highlight in this picture, we have wonderful, the first group outside of our institution that we trained in these procedures is in North Dakota. So Dr. Regan Stewart got a call and an email from folks in North Dakota Child Advocacy Center saying, we have a real problem. This is prior to COVID. We can't get to our families. We have a shortage of mental health professionals. We have families traveling hours for forensic interviews and services. How can we use this paper that we just read and apply it to North Dakota? So we started this first training collaborative, and ever since, our partners in North Dakota have been fundamental in creating these trainings you're seeing today in material. So I just want to acknowledge them. So when we're setting up for telehealth, there's a number of workflow considerations we have to keep in mind. And I just have to say, I can't even imagine what it was like for so many providers to be thrown into this without training or guidance. And I commend you if you had to do that this year. I want to honor you and also acknowledge you might be a little bit burnt out. So I hope you can listen to this now and hopefully receive information that will be useful moving forward. And so you won't have to reinvent the wheel. The first thing we're doing telehealth, TF-CBT via telehealth, is you have to have a good marketing campaign for this type of service. Families may be familiar with technology, But in particular, Hispanic Latino families may not have equitable access to equipment, internet. We have multi-generational families where perhaps the children are more aware of technology, have greater digital literacy, but may have a caregiver who may not be as aware of new technology. So we just need to be very clear in our messaging. As you notice, developing a flyer might help. You have to state the advantages, what telehealth is and is not, and is it effective? And all materials should ideally be translated and done in a very culturally sensitive manner. On top of that, you need to consider how to train your therapists and your staff, protocols, procedures, how to address screening, maintaining fidelity, which we'll be going through in this part of the webinar. So the first thing first, telehealth equipment. And it might seem like a no-brainer, but we've noticed a lot of challenges with clinicians, right? And clients. So in an ideal world, you want yourself as a clinician to have your own desktop and laptop and not a cell phone, because you can't share screen on a cell phone oftentimes. You might get more interrupting text messages. You might not be able to see your patient correctly. You also want to have a good webcam that's high resolution, that has good lighting, and a headset is fundamental. We need to have a headset, preferably with a microphone, where we can ensure privacy, and also our patients can listen to us better. This has been, I think, the biggest challenge, reliable internet connection, and we're working, remember, with that case management piece of, if there is no internet, what local programming exists, loaner programs, what free services can we get for families? And in some situations, we have to send our clients to different locations that have a private place but access to Wi-Fi. Dual monitors are ideal so that you can see your patient on one screen and share your resources on the other. But if you don't have that, that's okay. And finally, it's important to think about platforms, and that they're HIPAA compliant, that they meet your needs. I noticed that, for example, at my institution was recently switched to DocSeeMe, but we're still allowed to use another platform called Vigio, which fits better with my needs. So kind of test them out, trial with their trial periods, and make sure that they're HIPAA compliant and can provide documentation of such. Now, the patient, ideally, we want them to have a computer, a tablet, but in a worst case scenario, a smartphone will do. If it means not getting therapy and having to do it on a smartphone, we'll choose a smartphone. Plus, there's data from the Pew Center showing that almost 80% of Hispanic Latino families report having a smartphone in the home. So there's greater probability of having access through that mechanism. Internet connectivity, though, is always going to be a challenge that we need to assess. And if you can, all of our program, because we're blessed to have a grant by SAMHSA that funds this and other grants, we have a loaner iPad program where we provide the equipment, cellular data enabled iPads, so that families don't need to worry about internet and they can use it. And we work with our IT department to lock that iPad down so that all they can do is access our program and nothing else. And this is really important. We recommend that you buy something like an OtterBox Defender case so that your equipment is protected, that you provide headphones to the patients. And just so you know, approximate data use is 1 to 2 gigabytes for 4 sessions. So if you're thinking about doing this, you want to make sure you have 1 to 2 gigabytes per month that this family will be having this loaner equipment. This is another cool example of the North Dakota team just being amazing. They quickly realized we could further engage families if we sent them a teletherapy box of typical supplies we would use in in-person services, but we're going to make sure they get home with a loaner iPad. So crayons, stickers, bubbles, all the things we use in our work with children, because just because you're doing telehealth doesn't mean you can't use real objects, that you can't, ask the child to draw while they're showing you what they do. So I want to keep this in mind. And at the end of this presentation, you'll see a website where you have PDFs of all these protocols, of all of these examples of how to build your own teletherapy box so you can get started and not have to reinvent the wheel. So first things first, we need to do a phone screen. We need to make sure that we know that our families understand what is telehealth and that we're assessing for vision or hearing difficulties, safety or self-harm, impulsivity, the age of the child is important, privacy at the home. So we're already assessing, will this patient be appropriate for telehealth services, or during a pandemic where we have no other option, which children will we need special accommodations for, and make sure we have a caregiver present to address some of these concerns. So it's very important to start that psychoeducation process on telehealth, get signed consents, get the loaner equipment out there, and utilize electronic methods as much as possible that your institution or your organization allows, such as DocuSign, for example. This is an example of our barriers to treatment sheet. It's electronically fillable, where our case manager will go through these barriers to understand the unique needs and make sure we're connecting this family to address these needs so that we can start TF-CBT via telehealth. So it's collaborative from the start. On top of that, I think one of the biggest challenges I've seen in our clinicians that we supervise working with Hispanic Latino families during COVID has been this assumption that our job is to just do the therapy, but our job is really to educate and provide support on the platform. So we recommend creating tip sheets for families on the platform. We recommend that there's a time you set up pre-therapy, pre-assessment to really start going through how to connect, troubleshooting, do a test call. And that also means that as providers, it's almost like we've had to develop a new competency to provide trauma treatment with our Hispanic Latino clients, which is digital literacy. I'll confess, when I started doing telehealth, maybe 5 years ago, I was really scared. I felt like somehow it would be different. How do I adjust safety? What do I do if the connection fails? And I think even though it's hard to admit, really you learn by doing. So we need to be first informed, which is why you're in this webinar. We need to read, which is why you're going to look at the resources after this. But the third thing is we need to have a dialogue with our families and say, we're going to figure this out together. There's going to be bumps around the way, but here's some tip sheets, here's some strategies that we're going to work together so that we facilitate this. And I think culturally, building that bond with our Hispanic Latino families from the get-go, that we're a team, really helps them engage in trauma-focused treatment via telehealth. So this is an example of an easy tip sheet that we would have in Spanish as well, where they have the visualization of what they're seeing on the screen, a step 1, a step 2, and you want to make it as easy and as accessible as possible. So get someone on your team who's savvy with doing these tip sheets. Canva is a great website for free where you can make beautiful fact sheets. So, the sky's the limit. And you also want to make sure that you're actively creating a safe space for therapy. So one of the challenges that arose during COVID that I hadn't seen as much in my work doing and our work doing before COVID was this issue of home space. So prior to COVID, maybe more kids were at school, some people were at work, so there were more options in the home. But all of a sudden, we have this need for space, and we know that many of our Hispanic Latino families are living in multi-generational homes or multiple family members in the home where space may be limited. So it's important to creatively problem solve these challenges. And some of the things we've had to do, for example, is be flexible. If the only private space is a bathroom, then we make sure the bathroom with a caregiver is nicely engaging. There's a good scent, we have a place to sit, and there's a locked door, and we do therapy in the bathroom. And I think it's time to evolve and say, no, this is the way of doing things. No. The goal is access to care. We're going to work around this. Noise machines are relatively inexpensive. We can loan that to our patients too. And we need to discuss expectations for therapy. If you've done telehealth during COVID, you have had a family right now that's shown in their pajamas, or you've seen maybe things you didn't want to see on screen. So providing etiquette, just as we would when patients come to our therapy office, of how to dress, the importance of the caregiver present, which we'll talk about in a second. So we've addressed kind of the need for a private location, but we also need to keep in mind what's behind us. So, during COVID, we all kind of noticed if we don't have a home office, we need to create one. So how can we make sure that what's in the background is affirming, inclusive, not offensive, also that it's appropriate, and to the extent we can, neutral, right? Ensuring that when you're in front of camera, you know the identity of your patient, that your caregiver's meeting with you before every session, that you have emergency contact information readily available. And also for self-care, we need to space out appointments more, I've noticed, precisely because telehealth requires so much visual, five senses strain from the provider, and we don't have that in-person feedback that gives us, re-energizes us. So it's not, I think, the time to schedule appointments every, hour, but maybe leaving some 20, 30-minute breaks for ourselves to recharge. That's another unique adaptation. I think other do's and don'ts to explain to families that we must discuss as part of the introduction to telehealth, right? So by now you've noticed this is not just let's start TF-CBT. We need to have a pre-session to educate into this modality of how to make sure TVs and radios are turned off, phones are on silent, everyone must be fully dressed. It is not appropriate to be laying in bed while doing your session, and explaining why. No driving or sessions where there's no privacy, like at a Walmart or a pharmacy. And I think we need to have grace for our families. It is not on them to assume, oh, I shouldn't have done that. We need to explain why privacy is important and why we can't have sessions that we don't have their full attention, and that no smoking or drinking is allowed, just as if we were doing this in person. I think furthermore, for Hispanic Latino families, we have to consider confidentiality as well. All of a sudden, this kid, everyone in their family knows that they just went in to see their therapist. So how do we work with the caregiver to protect information, to not put the child in a vulnerable position of disclosure, to educate and other family members and destigmatize mental health services? And I think we also need to see the benefits. We have a unique opportunity to get to see the child's unique context, environment, and not just hear about it. And even incorporate family members that normally wouldn't, like abuelitas, tios, into treatment if caregiver and patient agree, to promote these strategies we're trying to learn. Also, I think, another big consideration that I've had to learn is, as a supervisor, as someone who's in charge of training others and supervising and providing my own services, I can't be out of the know in troubleshooting. We've all had to become kind of IT experts in a way, and that comes with practice of noticing what works, what doesn't in your own practice. So always making sure that you're addressing these connectivity issues and creatively problem solving. I think the next big wave will be access to equipment, access to technology, so that we can create more equitable services for Hispanic Latino youth. Now let's talk about relevant protocols, safety, and ethics. I think by now we should all be very familiar with the American Telemedicine Association guidelines and the American Psychological Association telehealth guidelines. But if you're not, please check these out. They're great documents, super updated now after COVID. And more importantly, be attuned to your local state licensing boards on the latest telehealth guidelines. And note that if you haven't heard, please read about PsychPact. It's this new movement that many states are introducing legislation to their states so that all states who have legislation can practice across state lines with an e-passport. So PsychPact is also something I would encourage you to read more about. In terms of informed consent and consent to treatment, do you have an existing consent? And if so, are there any specific telehealth language? And if not, you may have to incorporate what telehealth is, the the limits of confidentiality, potential risks, which include loss of video connection, unclear sound or video feed, or perhaps loss of privacy. So these are all things that we need to remember to include in our consent forms and to assess with our legal counsel and our local boards whether this is approved for our unique states. I encourage you, like I said, to explore moving forward, even post-COVID, into the era of electronic signatures. They help our families. Oftentimes we lose so much in getting a actual written signature when we could be using documents like programs like DocuSign, for example. And always consult with your regulatory bodies, but the language that we've included here is in general something that we include in our summary notes and in our informed consent. I obtained verbal consent for this patient to provide virtual electronic communication, etc. So you'll have these slides for your reference. Another complication of COVID and working with our families has been, do I have consent for all this electronic communication? You know, do patients prefer email? Do I have their permission to send email? How is this email being secured, and do they know the risks of sharing information this way? So, you know, we don't have time to go comprehensively into all these procedures, but I want you to be thinking about this. And how does this relate to the Hispanic Latino families you're serving in terms of educating and also hearing their concerns about telehealth, right? So a lot of our families might not feel comfortable with this modality, and also troubleshooting that. I think it's important too, if you're thinking about starting a loaner program for equipment, make sure you have an equipment tracking document where you know what checked out, when was it sent, what was a tracking number, what are your checkout procedures and receiving procedures, how will you get the equipment back, that you get families to sign a loaner agreement that they're going to take care of it, that they're going to only use it for therapy purposes, that they're responsible if it is lost. I think Dr. Stewart mentions in all of the top is our program, telehealth outreach program, maybe we've lost 3 iPads out of more than 100 that we've loaned. It happens, but it's not the norm. In fact, most families return that to us intact. It's dirty. We need to clean it because it's been all over the place, but families really take care of this equipment because they value it so much. And especially our Hispanic Latino families are grateful to have access to bilingual, bicultural providers now because of this technology. So I can assure you that this is not as hard as it sounds. This is an example of a cleaning protocol that, you know, we encourage you to think things through from beginning to end and start with a pilot patient and see all the issues that came up and check out our resources webpage so that you can start this and build as you go. Let's talk about emergency protocols. This is really important because we are in a setting where there's a camera between us. And oftentimes I invite my trainees to think about the following. What is our emergency protocol in person? If you really had to think about that, you would quickly notice, well, I assess risk. I determine what the level of risk is. I do that asking questions. If I'm concerned, I bring in the caregiver. We have a chat as a team. We determine next steps in terms of safety planning. And if I don't feel like this caregiver can keep this kid safe, I would call the ER or ask the caregiver to take the child to the ER and follow up. Well, that is exactly the same protocol in telehealth. The difference is the following, that we need the contact information, cell phone, and full name and physical address of where that child is. And we need it from the caregiver, another individual living in that home, and some neighbor, someone that we can get a hold of if we can't reach anyone. And we always need to double check that information at the beginning of every session. So safety protocol must be put in place before beginning TF-CBT via telehealth. The second thing is, we always recommend that you explain to caregivers this protocol that they need to be in the home. They can't go grocery shopping while you're in therapy with their kid, that they need to be easily accessible. In case of an emergency, you will be bringing them in to the room so that we can all discuss what to do next. They also need to be aware that if you can't reach them, you will be calling emergency services, 911, your local mobile crisis unit, and they will be arriving to that home. And the last thing too is I recommend that you have the numbers readily available of the local police station in case for some reason you also need to involve law enforcement. always discuss, don't assume that it won't happen, but also keep a realistic view of the probability rate in your own practice in person. How often did you enact an emergency protocol? And the reality is it's not very often unless you work in an inpatient unit. So keep that in mind. The telehealth note, this is very state dependent and bill of insurance dependent, but these are the general essential components that should be in a telehealth session note. The platform you use, that it's HIPAA compliant, the telehealth site, where you were located, where the patient was located, including the safety procedure you used, very brief summary, any modifiers that your billing insurance company wants or your electronic medical record requires. And it's an example there of a blurb that we use in our notes in case it's helpful. So the last thing we're going to talk about in the last few minutes, and make sure we leave room a few minutes for questions. Dr. Miranda, we have until 2:30 or 2? I just want to make sure.
2:30 with questions and answers.
So we're on good time. I want to make sure we leave a good like 20 minutes for questions. So now let's talk about application. What does trauma-focused CBT look like via telehealth? And this isn't an actor patient, but really that's what you would see. Dr. Stewart is in her iMac looking at this patient, and you would see the name of the patient in the bottom, and the patient would see you. And it's important to first screen, is my patient appropriate for telehealth? And for trauma-focused CBT, we want to look at a few things. So the first one is, are there any externalizing problems? And by that, I don't mean a kid who has problematic behaviors. That's most of our kids in TF-CBT. But will this kid be throwing the computer, the iPad? Will they try to harm themselves with these objects? That's a level of risk and externalizing behavior that may not be appropriate for telehealth. Or we might need to creatively problem solve. What if we have a kid with active current suicidal intent and plan? Just as you would with any therapy, you would recommend this child be seen first at an ER by a local emergency visit, by a psychiatrist to determine appropriateness for outpatient treatment, right? Or what if we have a young child? So TF-CBT is from 3 and up. So prior to COVID, we did not really recommend TF-CBT under age of 7. We recommended in person for those kiddos. We've had to since adapt. And to our surprise, we've been able to do TF-CBT with younger kids. However, we have to engage the caregivers more actively in sessions, whereas normally you would meet with the caregiver individually and then with a child individually. We're doing more conjoint sessions to teach skills, right? So that's an example of an adaptation. Another adaptation is reducing session time. Maybe this kid is fidgety, so we can't do a typical 45-minute session. So we'll do 15, 20-minute sessions, but we'll just prolong treatment. Or maybe we bring the caregiver to do some activities, the caregiver leaves, 5 minutes alone, come back. So it's important to not just say, hey, we can't do it. We need to keep assessing and creatively problem solving. And the goal is, what accommodations will this child need to be successful in telehealth if that is the only option we have? Post-COVID, what accommodations do we need for telehealth to be successful to increase access? And if the answer is it would be better for this person to come in person and they have the ability to do so, then by all means, we would switch to in-person. So how do you administer assessment measures via telehealth? Really, I love it, because what we do is we share the screen with the question and the options like you see on those pictures, and we read those questions to the caregiver or the child, and we ask them to pick an option. So it's really a useful visual tool. Another example of how we collect measures in other clinics is using online questionnaire completion formats like REDCap or Qualtrics, right? And another way is just good old-fashioned verbally. You read them, the parent answers, the kid answers, and you write them down on your piece of paper. So really that is pretty self-explanatory. We just need to make sure that it works for a family, and that really what I'm more concerned about is that you have appropriately psychometrically sound measures in Spanish if you're working with bilingual families or monolingual families, and that the language is appropriate and understandable. That's really what we've struggled with current standardized measures, and have had to do a lot of work to modify language. How do you provide psychoeducation in telehealth, TF-CBT via telehealth? So we do a number of things. So our amazing interns, postdocs have done a wonderful job, Meg Wallace, of creating resources such as trivia games in PowerPoint. And the good news is most of the things you see here will be in the website I'll show you at the end, where you can download them ready to go, and you can edit these PowerPoints to meet your needs. So you don't need to reinvent the wheel. There are card games that we've transformed electronically to PowerPoint. There are books that are scanned or available on the internet where you can show the kid and go through some psychoeducation materials. You can also include a digital copy of a Word document or a workbook and have the type what the child is saying. Or if you're using a platform that allows a whiteboard feature, they can write their answers on the screen. So there's really a way to adapt this electronically. We just need to make use of our digital resources now more than ever. Now, how do we do parenting skills via telehealth during COVID? I think the most important thing we've all realized is that any provider offering mental health services to a family has had to really stop and notice that this has been a very stressful and unprecedented year, and that our families and caregivers are struggling, and that we need to make space for not just the problem that brought them into therapy, but the broader context. And on top of that, our Hispanic Latino families have been disproportionately impacted by COVID, mostly due to the types of jobs available for our Hispanic Latino families, frontline jobs. I cannot tell you how many disparities I've seen in our clinic. So I supervise a 100% Hispanic Latino immigrant serving clinic, and almost every patient has either gotten COVID or had someone die from COVID or had a family member have it or die. Meanwhile, I'm hearing from other clinics that serve predominantly affluent families, oh, not really. So I'm just very concerned about the disparities we're seeing, and how our children who are already in trauma treatment, perhaps for something unrelated to COVID, now have additional adversities, grief, loss, compounded by already existing tension about potential immigration concerns, deportation concerns, financial concerns. So again, that three-pronged approach, it's not just it's not just evidence-based treatment, it's case management and understanding of the context. We need to connect families with community support, like free lunches, community food deliveries, and make sure we're discussing how much are you watching the news. A lot of our Hispanic Latino families belong to WhatsApp groups, and WhatsApp is a messaging application where it's like a network, and they're hearing firsthand from other Hispanic Latino families what's happening, who's dying, where the resources are, where the tragedies are happening. We need to make sure that we're limiting exposure to that constant bombardment of tragedy and information, and give parents a break and permission to step back. Because it can get overwhelming. And the National Child Traumatic Stress Network has phenomenal fact sheets in English being developed in Spanish for this type of need. So please don't reinvent the wheel. Please check out nctsn.org. Going back to TF, how do we relax? How do we teach relaxation? We do a number of things. We show videos, interactive videos where we can time the breath. We use newsletters and PowerPoints to provide psychoeducation on relaxation, or the good old deep breathing where the child gets to see you and they get to show you. The therapy box where you just send them bubbles. That's one of the therapeutic tools we can use in person, in hand, so they can show us how they blow a bubble and practice that relaxation. There's also great opportunities for you to have manipulatives and show the child progressive muscle relaxation with a stress ball, and doing good old-fashioned drawing and show it to your client. So really you can use the tools you've already been using. For effective identification modulation, which is another component of TF, we do a number of things, but we love the use of YouTube videos. And if you don't have the broadband to show the video because it'll eat up a lot of data, you can put it in your cell phone and show it to the patient on camera, or you can send them the link so they can look at it on their own. So it's really cool to be able to use all these tools. We teach cognitive coping in TF-CBT, how to identify thoughts and their connections to feelings and behavior. So just as you would in person, use a worksheet, you can use it online. It would just be on Word. And we can also use awesome fillables. So these are Word documents where the child is going through an activity and you can write in what they're saying. In this case, you know, you're asking, the dog is staring at me. He looks mean. I bet he wants to jump on me. What is this girl feeling? And you would write it down. This is another example of getting creative of your childlike superheroes. How can you turn a comic strip into an electronic activity to practice identifying thoughts and feelings and behaviors? Really, what I've noticed during COVID is a lot of clinicians starting out feeling uncomfortable because it's multitasking, right? It's not something we're used to, being on the computer while talking. It feels impersonal, but over time, getting used to, just as we had to get used to taking notes while we were in person doing therapy, or just as we had to get used to perhaps doing an activity while we made eye contact. So it's just retraining our way of interacting electronically. And again, if you remember, my purpose here is access to care. My purpose here is so this kid won't go without treatment just because we're locked inside a home or just because of transportation. Then we start to feel more flexible and more willing when we remember the why, el por qué. The trauma narrative, there's a lot of fear sometimes of how do we do this via telehealth? What if the kid goes in crisis? Remember, that's a low probability event, number one. And number two, what would you do if it was in person? If your kid had a crisis, you would get the caregiver, or you're going to do that via telehealth as well. But really, for trauma narratives, I love telehealth because already in-person services, I was using my laptop to write down and type faster what they were saying. Now I can do it in the computer while the kid sees live what I'm typing, or give them power to type themselves. We can incorporate clip art, PowerPoint. We can do so many things electronically for that trauma narrative. The important thing too is to remember you have a chat function. So you can use in these platforms that as a way for the child also, they don't want to tell you verbally. Kids these days are more willing to just type it out or text it to you via that chat. So what we've noticed is greater engagement actually from the Hispanic Latino youth in TF-CBT because they're doing it via telehealth. So really, it's about us. This has become an issue mostly about clinicians feeling uncomfortable or access to internet or equipment. Those have been the main barriers we've noticed. And in TF-CBT, there's this session where the caregiver joins and the child shares their trauma narrative. And that's a picture of me and my sister, Natalia, doing a mock-up of this. But basically, what we're trying to show you is camera positioning is important. So you should be making sure that the child and the parent are in camera view, that they're in front of you, and that they can see the screen where the child can read the trauma narrative. And it's okay to redirect. If you don't see your patient well or they're too close to the camera, it's okay to say, hey, can we take a minute so I can make sure I see you? If you have to do it because the child is at home and the parent is working, just as you would a FaceTime call, you kind of do a conference call and you make sure the parent and the kid can see each other on the screens. So this concludes the presentation. What I wanted to leave with you are some additional resources. The screen on the left is a website that we developed during COVID to really address the unmet needs of resources and information on TF-CBT via telehealth. So you can find resources that you can download for each of the components. We have also the exact same resources available in Espanol, in Spanish. The website is telehealthfortrauma.com. You can also get there with a Spanish name, telesaludparatrauma.com. We have free webinars on there to get you more information and as a refresher. And all of our citations of our lab are there as well. The paper on the right is something that I definitely would encourage you to read. Dr. Dewicki, one of our amazing postdocs, Meg Wallace, Dr. Nicasio, Dr. Villalobos, and Dr. Hernandez and Stewart wrote this paper in The Behavior Therapist, and it's practical resources, recommendations, implementation tips for telehealth with children and adolescents during COVID. So please read it if you want more information, because it's one thing to hear it from academics. It's another thing to hear it from people who are doing this every day. So I'm really excited to promote this paper. So with that, thank you so much for your time. I purposely want to leave as much time for questions, but Dr. Miranda, I'll give you the space now to give us further instruction on that.
Yes, and Marie will do the questions.
Okay, we have a question for you, Dr. Orengo, that reads, when you engage the parents in therapy, will you call it family therapy, or the engagement is mostly for feedback and follow-up?
That's an excellent question. Within the trauma-focused CBT model, the caregiver is you're required to meet with the caregiver at every session individually, or with the kid and the caregiver, to practice this skill, right? And so it's a model that is actively engaging the caregiver. In other forms of family therapy, it just depends on the modality you're using and the evidence-based protocol you're using. So I don't know if that answers your question.
Okay, thank you. We have another one. Should the intervention or program include the provision of free video technology, phone, tablet, etc., to service users? Have you seen this done? And if so, how did it go?
That's fantastic. So in an ideal world, if I could wave a magic wand, the answer is absolutely yes. I think that to the extent we can, we have to minimize barriers in access to care for Hispanic Latino youth and families. So what you're describing is called what we call a loaner program, a technology loaner program. Our program has successfully done this for the last 4 or 5 years, where we have funds where we buy data-enabled iPads, headphones, OtterBox cases, therapy toolkits of materials, and we mail that to the family or take it in person. We have them sign a release saying, I've been given this, I need to take care of it, I won't use it for any other purpose other than therapy, I will return it when therapy ends. And I think that that is a huge reason why our completion and engagement rates are so high, because once you get them access to technology, that's when you really can deliver the evidence-based treatment.
Thank you so much. I have another one here. I'm not very clear on it, but I'm gonna read it anyway. And
Sure.
if the person wants to comment about it. Hi, are these something that can be shared so we can use this worksheet? I don't know what.
I think
Yeah.
I know what he or she means, or they mean. Yes, so anything that you see on our website is meant for you to share, to distribute. You can edit the documents. I will say, in order to practice trauma-focused CBT, you have to be a certified TF-CBT clinician, and you can get more information on certification in tfcbt.org. However, a lot of the components that are used in TF-CBT are tenets of CBT with children. So I encourage you to look at the worksheets, look at the PowerPoints, and adapt them as necessary, and you may absolutely share.
Thank you so much. If any of you, I think we have time for another question. You can type it on the questions tab. We don't have any more questions for now, but I'll give it a minute. If anyone wants to ask Dr. Orengo any more questions, you're more than welcome to. It was a wonderful presentation. It was brilliant. We had a lot of comments about it. I have one of our content creators text me and said that she was watching the presentation and it was wonderful.
Oh, that means so much. And I just want to say, our team is currently awaiting news of whether we will be funded for another 5 years. And if we were funded, we're very excited to report that our work will be in part based solely in Puerto Rico. And our whole goal is to create trauma-informed schools and mental health centers where we can have clinicians train in TF-CBT via telehealth. So if you are located in Puerto Rico, stay tuned for more information. And if not, please email me. And I don't believe I have my email address here, but it should be in the handouts. So. And there's an evaluation survey, right? And that we would like you to fill. There's the code there.
Well, there's our emails, and also, yes, like the doctor said, the evaluation, it's really important for you to fill it. It only takes a couple of minutes. You can go to the link in the presentation, or you can scan the QR code. I have one comment here. It says, I just want to say this presentation was great. I am bilingual therapist certified to CBT, and this was great information. We have a question. Does MUSC offer training opportunities and or support for bilingual clinicians who are practicing CBT?
Yes, absolutely. So we have a number of grants that are now more focused on training outside of our institution. So please check out telehealthfortrauma.com. You'll find our email address there and contact us. And if I can't help you, our team can't help you, we know someone who will. So our whole goal is to share resources in an open access format to make sure every kid has access to treatment. So please, please, please contact us. We've done a lot of translation of documents in Spanish. We don't want you to have to reinvent the wheel.
Thank you so much. We have another one here. Can TF-CBT be adapted for adults who had childhood trauma?
Excellent question. So the equivalent of TF-CBT for adults is called prolonged exposure therapy, or PE, or cognitive processing therapy, CPT. So these are the evidence-based treatments for treating trauma in adults, even if they happen in childhood, okay? TF-CBT is only for ages 3 and 18 because it's developmentally adapted. So please Google PE web or CPT web. These are free online courses where you can learn more about these two treatment modalities that are evidence-based for trauma in adults.
We have a lot more comments. People thanking you for the amazing presentation. Just want to say thank you for helping us, and thank you for making the Puerto Ricans proud.
Woo, Boricua. I'm so excited. Maybe one day we can do this in Spanish.
That can be a possibility for sure. Dr. Miranda, are you? We have last one. Sorry.
Yeah. Okay.
Yeah. Any suggestion on using TF-CBT with unaccompanied minors?
Yes, in fact, Dr. Miranda must be like smiling because I will be doing a webinar with that specific topic in mind. So please check out the listings. I believe that's coming up in May. But the long story short is this. Almost every child client patient that I've seen through our clinic at MUSC has had some sort of immigration related trauma and has been or has had a parent in a situation of custody at the border. So there is data showing that TF-CBT is an effective treatment for this population. And really, we don't change the model because trauma is trauma. What we change is the psychoeducation, the approach. So please stay tuned for that webinar where you'll learn a lot more of adaptations. And also, nctsn.org has fact sheets on implementing trauma treatment with unaccompanied minors.
That's awesome. That's awesome news. Everybody's getting really excited in the comments.
Sign up. Yay.
Yes. Yes, please stay tuned.
If you want to close.
Yes. Okay. Thank you, Rosaura, for an excellent presentation and for sharing amazing resources with our audience. Please stay tuned to our website. We will have different webinars related to unaccompanied minors. Dr. Rosaura Arengo will talk about trauma-informed CBT. For unaccompanied minors, we will also have mental health assessments for unaccompanied minors, and also community-based practices to reduce barriers and access treatment for these children. So thank you so much for being here, and see you in our next webinar.
Do they need to complete the poll, or we're good?
We're all good.
Okay, well, it was very nice to be here, and I hope you have a wonderful rest of your afternoon. Un abrazo.
Gracias.